This year's campaign is Preventing Antimicrobial Resistance Together. This theme underscores the collective effort required from healthcare professionals, researchers, policymakers, and the public to conserve and protect the effectiveness of antimicrobials.
With that in mind, we will hear from Dr. Flanagan, who will share with us his knowledge around different courses of treatment and the challenges he faces as a microbiologist at Salisbury District Hospital.
Hello, I'm Dr. Paul Flanagan. I'm a consultant medical microbiologist at Salisbury NHS Foundation Trust. And part of my role is antimicrobial lead, promoting and monitoring the judicious use of antimicrobials throughout the trust. Targeted antibiotic therapy is normally defined as the use of narrow-spectrum antibiotics once the microbial culture, identification, and susceptibility results are available, potentially allowing you to move from broader spectrum empirical antibiotics. And this is important because the use of narrow-spectrum agents of proven clinical efficacy reduces the selective pressure for the emergence of multiply antibiotic-resistant organisms such as methicillin-resistant Staph aureus, gram-positive organism, or gram-negative organisms such as extended-spectrum beta-lactamase-producing coliforms and other multi-resistant gram-negative bacteria. In addition to that, the use of targeted antibiotics reduces the risk of the emergence of adverse events, particularly Clostridium difficile colitis, and in some cases, narrow-spectrum agents have lower drug acquisition costs than their broad-spectrum counterparts. So there are multiple benefits from using targeted narrow-spectrum antibiotics in the appropriate patient. As part of our antimicrobial stewardship ward rounds, the issues relating to antimicrobial awareness that we commonly see include, firstly, excessive use of intravenous IV antibiotics in a patient or in patients who have clinically improved on the IV antibiotics, whose inflammatory markers are decreasing, who are able to take oral medication, who are absorbing, and who don't have a clinical infection that requires a protracted course of IV antibiotics, such as endocarditis. And yet the patient remains on IV antibiotics for no obvious clinical indication. This may well be because the medical team perceive that IV antibiotics are required in a particular patient, or the evidence for that may be lacking, or that there was a plan to change to oral antibiotics and logistically they simply haven't got around to doing it yet. Secondly, excessive use of broad spectrum antibiotics as opposed to narrow spectrum antibiotics, both IV and oral. A good example of this is excessive use of IV comoxiclav or IV tazocin for community-acquired infections on admission to hospital, where they're not indicated according to hospital policy, or the use of oral comoxiclav for a proven Staph aureus wound infection, where flucloxacillin would be just as would be more appropriate, or a proven case of pneumococcal pneumonia, where on oral comoxiclav, where either IV, either benzoyl penicillin if you need IV, or oral amoxicillin would be more appropriate. Thirdly, the use of antibiotics to treat effectively what is known as colonization, where you get a positive culture at a body site at which the patient doesn't actually have any clinical symptoms. And the best example of this is the use of antibiotics to treat asymptomatic bacteriuria of the elderly or in catheterized patients, effectively a positive urine culture in an otherwise asymptomatic patient who doesn't have symptoms of a UTI or urinary sepsis, The urine was taken merely as part of a general screen on admission or when an clinical episode began. Simply because they have a positive urine result, it gets treated, and that increases the risk of adverse events, as we said before, and unnecessarily increases healthcare costs. Fourthly, the excessive duration of antibiotics, both IV and oral in total. In recent years, national recommendations for common clinical infections have been reducing the recommended duration of antibiotics. A good example of this is the recent NICE guidance on community-acquired pneumonia and hospital-acquired pneumonia, which are now recommending antibiotic courses of 5 days, or at least to review the patient at 5 days and see whether the patient can stop antibiotics at that particular point. Also, a lack of awareness that there are certain commonly used antibiotics that have high oral bioavailability and can be used orally to treat serious infections, deep tissue infections, in a patient who is able to tolerate oral medication and is absorbing because they achieve high serum and tissue levels. And this includes the quinolones, ciprofloxacin, levofloxacin, moxifloxacin, clindamycin, metronidazole, cotrimoxazole, and rifampicin. And finally, a lack of awareness that if a patient is known to previously colonized with a multi-resistant microbe, such as methicillin-resistant Staph aureus, MRSA, or an extended spectrum beta-lactamase producing coliform, ESBL, MRSA on the skin or mucosa, ESBL most commonly in the urine, and that patient then develops sepsis, particularly sepsis with no obvious clear focus, then their empirical antibiotic regime needs to include an agent with activity against those colonizing organisms in that particular patient. For example, the use of vancomycin or teicoplanin in an MRSA positive colonized patient, or the use of an agent such as meropenem in a patient known to be colonized with an ESBL coliform, at least until the antibiotics can be reviewed at 24 and 48 hours, and if needs be, then changed to a narrower spectrum antibiotic, dependent on the clinical situation.